Yesterday we had a overwhelming response. It was a fantastic response. Everybody was there very early also. Today I saw before 7 o'clock itself, Suma and Suhasini, some people have started logging in, and it was overwhelming response. As I said, it was, and class was also like that. It was really a must class week. Really, like it was an excellent way how you can deal with a class, and then every aspect of it, including the subject or the way it has been presented, the clarity, everything, and the speed, everything was perfect. So a lot of people asked for want to join and things like that. So I made it Facebook Live also through my account. I'm recording this event also, and then I'll put it immediately after that. One more thing is just to say at this point, we are also planning to hold a midterm CME from IAPA, Indian Society of Anesthesiologists, Pediatric Anesthesiologists. Dr. Elsa Madam, our Elsa Madam is the head of that IAPA now. She is the president. So she has given us the opportunity to do this particular CME. This is scheduled on 5th of September, evening session, again online. And there will be something like 3 to 4 lectures, and there will be also there is a panel discussion and some information capsule. Something like that we are planning, and also we are looking one pro-con session. So I'm still trying that. So that will be live on 5th of September, Saturday, from 4 p.m. onwards. We expect it to go up to something like 7:30, 8 p.m. So, sir can go ahead with your talk. I think it is almost, we are nearing 7:30 now.
Okay, right. So, very good morning to everybody who's on today's session. So, since it's a continuation of session 1 from yesterday, what I thought I'd do was just sum up 1 or 2 points that we kind of hopefully understood yesterday. And that is independently, we dealt with the distribution of perfusion in the lungs, and we also dealt with the distribution of ventilation in the lungs. And if you were to summarize that in 2 sentences, you can say that both perfusion and ventilation increase from the top to the bottom of the lung, while perfusion increases by a factor of 10 from top to bottom. Ventilation increases by a factor of 2 from top to bottom. So therefore, there is some inequality there. They don't increase proportionately. And that's probably the reason why we get differences in the ventilation perfusion ratio as we progress from the top of the lung to the bottom of the lung. Now, today's class, not literally speaking, but figuratively speaking, is going to be about a lot of pressures and tensions. Pressures being developed in the alveoli in the pulmonary system, and tensions consequentially being built up in the blood that is perfusing the alveoli. So it's all about pressures and tensions, not the COVID type of pressure or tension, but all pressures and tensions that drive any fluid across any membrane in the body. Once again, I'd love to start with what Anita and Tushar had mentioned. They talked about different types of pressures that are there in the pulmonary system. And the first that we need to understand is the intrapleural pressure. Fair enough, simple. It's the pressure within the pleura. And we all know that when the respiratory system is intact, there is a negative pressure inside the pleura. And this is because of the natural tendency of the chest wall to spring outwards, and the tendency of the lung, elastic lung, to recoil towards the hilum. And these two opposing forces, chest wall springing outwards and the elastic lung tending to collapse towards the hilum of the lung, would create a negative pressure within the pleura. And this is what we call intrapleural pressure. Now, if you were to imagine that the alveolus is like a balloon, and you're blowing up a birthday balloon, you can blow up the birthday balloon by blowing at the mouth of the balloon. And what we're doing here is we are creating a positive pressure at the mouth of the balloon in comparison to the interior of the balloon. And this is what we call trans-airway pressure. It's what we do in intermittent positive pressure ventilation, which we do in ICUs and in controlled ventilation in the operation theater. We put in a tube, we create a positive pressure at the entrance of the airway, and alveolar pressure being zero in reference to atmosphere, the positive pressure we create at the mouth end of the tube would allow or ensure that gases flow from the endotracheal tube, the entrance of the endotracheal tube towards the alveoli. And when we breathe out during expiration, the pressure within the alveoli exceeds atmospheric pressure, and therefore the gas tends to flow out. You know that we all know that in ventilators, it's only the inspiration that is active. Expiration is always passive and is created by the recoil of the chest wall and the elastic lung. So this is how the trans-airway pressures influence breathing. In spontaneous breathing, taking atmosphere as a reference point, we lower the pressure within our alveoli to an extent of -2 centimeter water below atmospheric. And to remember, atmospheric pressure is 1000 centimeters of water. So when the absolute pressure inside the alveoli becomes 1000 minus 2 or 998 centimeter water, air moves into the lungs, creating the tidal volume. And when the pressure within the alveoli becomes 1000 plus 2, 1002 centimeters of water, it becomes 2 centimeters higher than the atmospheric pressure, and expiration occurs. So essentially, all that we do in our normal effortless breathing is to drop the pressure within the alveoli to 2 centimeters of water below atmospheric for air to flow in, and 2 centimeters of water above atmospheric for the air to flow out. Now, what is transpulmonary pressure? Transpulmonary pressure is pressure across the alveolus. And we need to remember that this particular sentence, when the pressure inside the alveolus minus the pressure outside, I repeat, when pressure inside minus pressure outside is a positive value, then the alveolus expands. Okay, which is what is happening in, let's say, controlled ventilation or IPPV. We increase the pressure within the alveolus to a plus value. Pressure outside the alveolus is a minus value. So pressure in minus pressure out gives you a positive value, and the alveolus expands. And the reverse is true. When pressure in minus pressure out is a negative value, the alveolus collapses. And all these things are created during normal breathing, spontaneous breathing, by changes in intrapleural pressure. So the intrapleural pressure, as I mentioned yesterday, for those who attended yesterday, we can take it as an average value of -5 centimeters of water. So that's the pressure outside the alveolus. Pressure inside the alveolus, will take it as a reference of 0 centimeter water. So the transpulmonary pressure, which is the pressure across the alveolar wall, would be pressure in minus pressure out. Pressure inside is 0. Pressure outside is -5. So 0 minus -5 will be +5. Since it's positive, the alveolus will expand. And the opposite happens during expiration. So let's come back to where we stopped yesterday, okay, which is the pressure differences that happen from the top to the bottom of the lung. And I refer you to this diagram that is there on the left of this slide. Right on top, you have a value that says -10 centimeters of water. At the bottom, you have a value that says -2.5 centimeters of water. So it's a minus, remember, and therefore the pressure within the pleural cavity at the top of the lung is more negative than it is at the bottom of the lung. And the reason for this is, as I explained yesterday, I said that the lung is like a plastic bag filled with water. And if you were to hold it up, I don't see my own video, I hope you're able to see that. If you're able to hold up a plastic bag filled with water, the water will tend to gravitate towards the bottom of the bag, and therefore the bottom of the lung tends to become larger, the top of the lung tends to become narrower. Now, as this happens, the lung gets retracted away from the thoracic cage. more so at the top, and the negative pressure therefore becomes more negative at the top. And at the bottom, because the gravity has pulled the weight of the lung towards the bottom of the lung, that negative pressure becomes less negative. And that's the difference why we have a difference of 7.5 centimeters of water from the top to the bottom of the lung. Now look at all those dots that are there within the lung, and this is, you can say, something like representative alveoli in each of these parts of the lung. So let's take the topmost dot and imagine that is exposed to a minus 10 centimeter water pressure in the pleura around it. Going back to our formula, pressure in minus pressure out, 0 minus 10 would be plus 10. So the alveolus at the top of the lung is exposed to a pressure difference of 10 centimeter water, and it expands, let's say, to a certain extent. Coming to the bottommost slice, which is minus 2.5 centimeters of water, pressure inside is 0, pressure outside is minus 2.5, 0 minus 2.5 gives us a value of plus 2.5, and therefore the alveolus will expand to an extent of a pressure difference of 2.5 centimeters of water. Now, if you look at it, what you're saying is that the alveolus at the top of the lung is exposed to a 10 centimeter pressure differential, whereas the alveolus at the bottom of the lung is exposed only to a 2.5 centimeter pressure differential, and therefore the one at the top is already maximally expanded, which is what is shown in the bottom half of the diagram. There's a line joining the top black dot to the pressure volume curve, which is there on the bottom part, and my pointer is right now very close to the dot which represents the top of the lung, and now it's moving down to the dot that's at the bottom of the lung. At the bottom of the lung, that dot is in the more compliant part of the pressure volume curve, and therefore when we start breathing in from functional residual capacity, the gases tend to preferentially go to the bottom of the lung, which is more compliant, because the top of the lung, the alveoli are already maximally distended. There's no question of distending an over distended balloon anymore. So therefore, preferentially, as you breathe in from FRC, the gases tend to go towards the bottom of the lung. Now let's look at residual volume and the transpulmonary pressure at residual volume. Now residual volume, we know that we reach residual volume by forcibly breathing out from a point of functional residual capacity. And when we reach the maximum amount we can blow out, and we can't blow out any further, the volume of air that remains in the lung is called residual volume. So remember, we are putting in an extra effort to blow out that air, and this results in a positive pressure being added on to the pleural pressures. And that's the reason why you get now on the right side diagram, the pressure at the top of the figure, the top of the pleura at the top of the lung is now minus 4 centimeters of water, in contrast to minus 10 centimeter water. And the one at the bottom is plus 3.5 centimeter water as compared to minus 2.5 centimeter water, which was there at FRC, surely because we have now breathed out maximally, created a positive pressure of 6 centimeters of water extra inside our pleural cavity, and this has dropped the intrapleural pressure at the top of the lung to minus 4 centimeter water, and to the bottom of the lung to plus 3.5 centimeter water. If you were to apply the transpulmonary pressure equation here, the alveolus at the top of the lung is now exposed to 0 minus 4, which is plus 4, and therefore it will expand to that extent, okay? And that dot has now moved to the more compliant part of the pressure volume curve. Look at the bottommost part, the plus 3.5 centimeter water. Actually, the pressure in minus pressure out now is not a positive value. It is 0 minus 3.5, which is minus 3.5, and therefore these alveoli are actually collapsed. I hope you get the point, because I can't see anybody in the audience. So this is the point I want to drive across, that at FRC, you find that the alveolus at the top of the lung is maximally expanded, okay, and therefore it is not going to expand much more while we take in a breath, whereas preferentially the gases are going to go to the bottom of the lung at FRC, because the bottom dot is at the more compliant part of the pressure volume curve. In contrast, the bottom part of the alveoli or the alveoli in the lung are already in a collapsed state, as you can see in this arrow, and the top portion of the lung is now moved to the more compliant part of the pressure volume loop, and therefore when we breathe in from FRC, the breath preferentially goes to the base of the lung, and when we breathe in from residual volume, it preferentially goes to the top of the lung initially till the critical opening pressure of the alveoli at the lower part of the lung has been exceeded. And after that, the lower part of the lung will also contribute to ventilation as before. Now, this I've already explained. The lung falls away from the chest wall, creating a negative intrapleural pressure, which is more negative on top as compared to the bottom. At FRC, minus 10 centimeter water on top and minus 2.5 centimeter water at the bottom. That's because the lung is like a fluid-filled bag, and the intrapleural pressure is more negative at the apex than at the base, implying that the apical alveoli are more distended at FRC as compared to the basal alveoli, resulting in a more preferential distribution of gas to the lower zones as we breathe from FRC. And as you breathe in from residual volume, the gas distributes to the upper zones first. When the lower zones starts filling, once the lung reaches 20% of the vital capacity, which is the point at which the critical opening pressure of the lower alveoli has been taken care of. And after this, the upper and lower zones fill similar to normal tidal breathing. So this is basically just to bring out a point that intrapleural pressure plays a very important role in the way the alveoli are expanded. And depending on what point of our breathing we are starting the inspiration, the gas distribution will preferentially go to different zones of the lung. Once again, this is all with reference to the erect position, not in the supine or lateral or prone position. Right. This is a summary of this again. We have probably also learned in our earlier classes in respiratory physiology, I guess this has been covered, the two terms compliance and airway resistance. Now let's see how compliance and airway resistance will influence the distribution of ventilation. Excuse me. Right. So compliance by definition is the change in volume per unit change in pressure. And airway resistance is the resistance or it is the impedance offered to the flow of any fluid. It can be air in the case of respiratory physiology, it can be the blood vessel or vascular resistances in the case of cardiovascular physiology. All of these are fluids. Air and liquid are both known as fluids in physics. So all fluids will face an impedance to their flow as they flow through any tube. In the case of the lungs, it is the tracheobronchial tree. In the case of the cardiovascular system, it is the vascular structures. So these are the basic definitions of compliance and airway resistance. Now let us see in this diagram how variation in pulmonary mechanics encompasses compliance and airway resistance. Now let us see how changes in compliance and changes in airway resistance can alter the distribution of ventilation within the lung. The topmost bell-shaped diagram here, labeled as A in green to the left of it, implies a normal ideal alveolus, which has got a normal compliance and a normal airway resistance. Come down to B, which is indicated by a red B there. The alveolar wall has now been indicated as a thickened wall. Thickened wall implies that the compliance of this particular alveolus is less, and therefore the volume change that it is going to undergo will be achieved very quickly because it's a very small volume change. Change in volume per unit change in pressure is going to be very small because of the thickened alveolar wall, and that is what we call decreased compliance. So A is a normal alveolus with normal compliance. B is an alveolus which has got a thickened alveolus, which is an example of an alveolus that has got a lowered compliance. Going to C, you can make out that the airway leading to this particular alveolus is thickened as compared to the normal airway in A. So C is an example of an alveolus that has got a narrowed airway leading into it, and this is what we call increased airway resistance. So A is an example of normal compliance, normal airway resistance. B is an example of decreased compliance, normal airway resistance, and C is an example of increased airway resistance and normal compliance. I hope I'm not playing around with too many words. So now let's look at the corresponding graphs on the right side. The x-axis on this graph indicates the time factor, which is divided by the dotted vertical line running from top to bottom into inspiration and expiration. So the initial part of this graph is inspiration, and the later part of this graph is expiration. And the dotted line, vertical dotted line, indicates the transition from inspiration to expiration. Now let's look at the green line that has been drawn. Green by the alphabet, green alphabet A, indicates an alveolus that has got a normal compliance and a normal airway resistance. And therefore, it is natural that at the end of inspiration, this particular alveolus A has reached its maximum volume that it is capable of reaching. And after that, when inspiration stops, expiration occurs passively. So that is the graph explanation of the graph A for us. A, which is in green, indicates an alveolus that is having normal compliance and normal airway resistance. Let's come to B. And we said B was an alveolus. The color is red. So the red graph here is being produced by airflow into an alveolus that has got a decreased compliance. And we said that the decreased compliance means that it reaches its maximal volume much earlier in inspiration. So you see from this point onwards, if you were to look at it, possibly in the first 1/3 of inspiration, it has already reached its maximal volume. After that, any further time given to this alveolus, it will not increase in volume any further. It's just a plateau that you see there. And with that plateau, at the end of inspiration, when expiration is allowed to occur, expiration starts. Coming to the alveolus C, which is an example of an alveolus that has got increased airway resistance, but normal compliance, we know that it's much more difficult for an asthmatic to breathe, right? It is very similar to a non-asthmatic trying to breathe through a drinking straw or trying to breathe through a capillary tube. That is how an asthmatic feels. An asthmatic feels as if their airways are terribly narrowed. So when it is narrowed, the air flows in very slowly, very, very slowly. And as it happens, it may not even reach its maximum volume because there is a impedance that is applied to the flow of gases into this alveolus. Now, in our lung, believe it or not, we have alveoli of all these three types. Fortunately, for those of us who are young, when I say young, I mean less than 20 years of age, okay? The majority in this group will be over that age. If you're a smoker, then you no longer qualify into that category of young. So young people who are non-smokers, essentially, they will have normal airways with normal airway resistance and normal compliance. And majority of the alveoli in their lungs will be ideal alveoli. But as we get disease process is setting in, like asthma or COPD and things like that, you start or fibrotic lung diseases, you get changes in compliance and airway resistance. And this will be there even with normal aging process. Me at 66 cannot be expected to have the same kind of lung function as Manjunath, who is, I won't tell you his age, he's like our Devanand, forever green, evergreen hero. So he always is still goes for running and athletics and things like that. So his lungs are much more compliant and are much better off than my lung. So the point I want to underline here is that we all have different types of alveoli in us, and it is the spectrum of alveoli that results in ventilation, perfusion, distribution being altered. Fast alveoli are alveoli that fill rapidly to their maximum volume in the early part of inspiration. Take that as an example of the lung or that part of the lung with decreased compliance. And in contrast, slow alveoli, as for an example, an alveolus that has got an increased airway resistance, will take much longer for the air to flow in because of the increased airway resistance. And even given a normal duration of inspiration, these lung units will not fill up to their maximum value. And we know, we have been taught, maybe not the reason given, but we have been taught that when we ventilate patients with asthma or COPD, we need to give longer expiratory times, we need to give longer inspiratory times, and that's the reason for it. We want to ensure that those alveoli that have got an increased airway resistance by virtue of the disease are given enough time for the complete filling of the alveolus so that maximal function of the lung is achieved. So this is what we term as fast alveoli and slow alveoli. And this is created completely because of the difference in compliance and airway resistance in different parts of our lung. Now, there is another term that I want to introduce here, and that's called frequency dependent compliance. If we have a diseased lung with different lung units behaving differently, and we give a standard inspiratory time for these patients, you will find that in that inspiratory time, maybe 80% of the alveoli will get filled normally because they are normal alveoli. 10% of them may be having a low compliance, so they may have reached their maximum value in the initial part of inspiration. And let's presume the remaining 10% had an increased airway resistance, and those will never ever reach unless we give it a long enough inspiratory time. So when we have a diseased lung, and as we age, we don't have to have COPD or asthma or pneumonia. Our lung ages as we grow old. We will get region inequalities in distribution of ventilation. And this is the reason why breathing slowly and deeply is described as one of the yogic exercises in breathing to improve your lung function. Now let's go on to the overlap of ventilation perfusion. Whole of yesterday and practically about 25 minutes today, we've been talking about ventilation, its distribution in the lung in health and disease, and we've been talking about perfusion and its distribution in the lung in health. Now let's look at the ventilation perfusion ratio and how that is affected. This is a familiar diagram from what we talked about yesterday. We said that the red line indicates an increase in blood flow from the top to the bottom of the lung by a factor of 10. We also look at the blue line, which also increases from the top to the bottom of the lung, indicating that ventilation increases by a factor of 2. And you can make out that these two are overlapping at around the third rib. So around the third rib, you find that the red and blue lines are overlapping, which means it is around the third rib or around the third to fourth rib, which is where the hilum or the lung is situated. That is the point at which ventilation and perfusion are well matched. If you look at the right side of this intersection point, you find that the blue line is above the red line as you go to the second rib and the top of the lung, which indicates that ventilation is in excess of perfusion as you go towards the top of the lung. And the opposite is true. Blood flow is in excess of ventilation as we move towards the bottom of the lung. And the ideal situation of ventilation perfusion matching of a factor of 1 is achieved somewhere near the hilum of the lung, essentially between the third and fourth ribs. And this is what will be indicated when I bring in the next graphic, which is the green line. It's a curved line, and you can look at the familiar 9 dots on this curved line. Each of these dots represents one of the slices of John B. West model that we talked about yesterday. And therefore, the dot that is very close, right on top is, as you can make out, there is another axis that has been added on here, a y dash axis going from 0 at the bottom to 3 on top. And this is the ventilation perfusion ratio. So at the top of the lung, ventilation is in excess of perfusion, and it's by a value that is slightly higher than a value of 3. That means we have 3 times more ventilation as compared to perfusion for matching, is what I mean. And therefore, we have a component of wasted ventilation at the top of the lung. And wasted ventilation is another way of saying dead space ventilation at the top of the lung. And fortunately, as I mentioned yesterday, in the majority of us with normal healthy lungs standing upright, this is a very minimal area. Very small amount contributes to the dead space because the blood flow reaches almost up to the top of the lung in the erect position. Now, as we come down, okay, follow these dots, dot number 1, dot number 2, dot number 3. Dot number 4 is actually coinciding the intersection point of the red, blue, and the green lines. And that is the point at which the ventilation perfusion ratio is roughly equal to 1. Extrapolate the 4th dot to the right, and you will get a value of approximately 1. And where is that happening? Approximately around the third rib, which is we always say that the third and fourth rib is the region where we get the hilum of the lung. So near the hilum of the lung, most of the alveoli will be ideal alveoli. As you go towards the top of the lung, from the hilum towards the top of the lung, you get more of ventilation and less of perfusion. You get VQ ratios in excess of 1. And contrary to that, as you go towards the bottom of the lung, dot number 5, 6, 7, 8, and 9 are all values below 1. Okay, and the bottommost one is coming roughly to around 0.06. It's to this side, so it's around 0.6. So bottommost dot you extrapolate to the right, you get an intersection at around 0.6. So the topmost dot is giving us a VQ ratio of more than 3. Dot number 4 is giving us an ideal VQ ratio of 1 situated at the hilum of the lung. And dot number 9, which is at the bottom of the lung, is giving us the possibly the worst ventilation perfusion ratio of somewhere in the range of 0.6, which is kind of summarized in this diagram. So today I'm going to develop this diagram a little more. We already understood this, but in case somebody joined in for the first time today, I just spend a minute explaining this diagram. We have this is John B. West's 9-slice model of the lung. We have 10 rows in this diagram and 7 columns. And yesterday we covered the first 3 columns to the left. The numbers in purple or violet, 7 and 13, indicate the percentage of volume of the lung that is there in that particular lung slice. So the topmost part of the lung has contributes to 7% of the lung volume. The bottommost slice contributes to 13% of the lung volume. Column number 2, which is in blue, 0.24 to 0.82 at the bottom, just indicates to us that ventilation is increasing from the top to the bottom of the lung. Don't get confused with the number being more than a value of twice, because this is not the ventilation per unit lung volume. This is absolute ventilation of 0.24 liters per minute on top slice, 0.82 liters per minute at the bottom slice. Column number 3, 0.07 and 1.29 is essentially the blood flow increasing by a factor of 10 from the top to the bottom. And today we worked out the middlemost column, column number 4, that the ventilation perfusion ratio is a value of 3.3 at the top of the lung. At the bottom of the lung is 0.63. What does it mean? It means the lung units at the top of the lung are contributing to what we call dead space ventilation, and the lung units at the bottom of the lung are contributing to some kind of a shunt at the bottom of the lung. And somewhere at the 3rd or 4th slice is the hilum of the lung, and that is where we are getting the ideal distribution of ventilation perfusion, which is a value of 1. So you have a spectrum of ventilation perfusion ratios ranging from 3.3 on top, crossing through 1 at around the 3rd or 4th rib, and as you go down to the bottom of the lung, reaching a value of 0.63. Essentially, this means we are going from dead space, predominantly dead space kind of ventilation on the top of the lung through ideal alveoli to the bottom of the lung, which contributes to some degree of shunt. Okay, now we have another maybe 20 minutes to wind up. So I'll probably go a bit slow on the next couple of slides, because these are basically the clinical implications of the type of alveolus we are dealing with. Now I want to break up this diagram into several parts. So I will start with the top blue box. It is a top blue box which indicates O2, oxygen, equal to 150. And I've dropped the units just to make things easier. So it's 150 millimeters of mercury. Carbon dioxide is 0. Please read that as 0 millimeters of mercury. And from these numbers, we can make out that this is the composition of the air that goes into the lungs as we breathe in, right? And we know that as we breathe in, we also know that the normal tracheobronchial tree, starting from the nose downwards, will not only warm the gases, but will also humidify the gases. And at body temperature of 37 degrees Celsius, you find that water vapor being added on to the inspired air will contribute to a tension in the alveolar gases that reach the alveoli of 47 millimeters of mercury. So the blue box basically indicates the composition of inspired air. Again, things have been simplified just for easy understanding. Oxygen, 150 millimeter mercury. Carbon dioxide, 0 millimeter mercury. Is supposed to have a slightly higher CO2, but we make it 0 for our understanding. I'd like you to now concentrate on the red box, which is at the lower part of the diagram. The red box tells us the composition of the blood that is coming in from the right ventricle through the pulmonary artery and the arterioles up to the pulmonary capillaries. And the oxygen tension in the blood that is perfusing the pulmonary capillaries is 40 millimeters of mercury. That is basically venous blood coming through the pulmonary artery. And the carbon dioxide, after collecting all the CO2 from every living cell in the body, has now gone up to 45 millimeters of mercury. Right. So air, oxygen, 150 millimeter mercury, carbon dioxide, 0 millimeter mercury. The pulmonary circulation, pulmonary arterial blood flow, it brings blood into the pulmonary capillaries, has an oxygen tension of 40 millimeters of mercury and a carbon dioxide tension of 45 millimeters of mercury. And let's now forget the two diagrams to the left and the right of the picture. Let's only look at the diagram that is immediately in the midline between the blue box and the red box. So we're trying to indicate the composition of gas flowing in through the airway leading into that particular alveolus. And we're trying to see how the composition within the alveolus changes as this alveolar gas equilibrates across the pulmonary capillary with the blood that is there in the pulmonary capillary. I'd like to also, before going into those numbers, also draw your attention to a line, a two-colored line that is running at the bottom of the figure. To the extreme left, it starts as a red line and continues to the extreme right where it ends up as a blue line. Right in the middle, there's a little white separation between the red and the white line. And that is the point at which ventilation and perfusion are perfectly matched, which is a value of 1. Now, as you move towards the left of this figure, you're getting a picture, as you can see on the diagram. Sorry, I'll draw your attention to the diagram. You have pulmonary blood flow happening freely, but the alveolus has been blocked off for some reason, just for our understanding. So no ventilation, full perfusion. This is what we call a 100% perfusion state, indicated by the red circle here. So blood flowing through this particular capillary will not exchange with any atmospheric air, and therefore it will continue through as a shunt. And this is what we call an extreme shunt or a 100% shunt. Complete. So when you say VQ ratio, V is 0 in this case because ventilation is shut off. Circulation is 100%. So any number, 0 divided by any number gives us a value of 0. And therefore, you mean complete shunt. Let's travel to the right side of the diagram. To the right side of the diagram, you have a pulmonary capillary that is blocked. Okay, just for our understanding. And the alveolus is completely open. So here, ventilation is happening freely, but there is no circulation. So this is what we call a situation where the VQ ratio is some number divided by 0, and any number divided by 0 gives us a value of infinity. Therefore, if we were to take the two extreme examples, and this of course we call dead space, pure dead space ventilation. So if you move across the entire spectrum of ventilation perfusion ratios, starting with 100% shunt on the left through a normal ideal VQ ratio of 1 towards the right side, which goes to up to infinity or dead space ventilation, you can find we have alveoli resting in any part of this line, of this ventilation perfusion spectrum line. And fortunately for us, if you were to look at remember those two numbers that we mentioned earlier, we mentioned that at the top of a normal lung, the ventilation perfusion ratio is somewhere in the range of 3.3. That means we have not really moved too far to the right of this picture. Okay, to the right, I'm not getting my pointer, sorry. Okay, there it comes. So, okay, right. So now my pointer is just strategically placed just a little distance between the middle of this spectrum and to the right. Okay, so we're getting a VQ ratio of around 3.3. And as you move towards the left, you're getting some number less than 1, and that is 0.63. So most of our alveoli are lying centered around the ideal alveolus, and it's only in pathological conditions that we really go to the extreme shunt and the extreme dead space ventilation. So now let's get back to the middle of the diagram. If you were to say that gases flow into this alveoli with an oxygen tension of 150 millimeter mercury and a carbon dioxide tension of 0, we now have a pressure gradient that will drive oxygen from the alveolus into the blood. And what is that gradient? The gradient of 150 millimeter mercury minus 40 millimeter mercury. Okay, that is the oxygen values, tension or pressure values in the alveolus and the pulmonary capillary. And this gradient of 150 minus 40, a gradient of 110 millimeters of mercury, will ensure that oxygen diffuses across the pulmonary thin-walled alveolus and the thin-walled pulmonary capillary, what we call the alveolar capillary membrane at the start of yesterday's session. It diffuses across very rapidly, so that even before the RBC or the blood exits this particular pulmonary capillary, it has equilibrated to an extent to give a number of oxygen 100 millimeters of mercury and carbon dioxide of 40 millimeters of mercury. So oxygen diffuses from a level of 150 with a gradient up to 40 to finally stabilize at an oxygen tension of 100 millimeters of mercury, both within the alveoli and within the blood that is exiting from the pulmonary capillary, which will essentially reach the left atrium, the left ventricle, and essentially become arterial blood, systemic arterial blood, as we sample it from the systemic circulation, which is why we get a P small a O2 arterial oxygen tension of 100 millimeter mercury in the arterial blood that is leaving the left ventricle every single heartbeat. Look at carbon dioxide. Carbon dioxide in alveolar gas is 0. In the pulmonary blood is 45 millimeters of mercury. So you have a gradient of 45 minus 0, driving carbon dioxide across from the blood into the alveolus. And the physiological equilibrium is reached at 40 millimeters of mercury. So you get blood exiting the pulmonary capillary having a P small a CO2 arterial carbon dioxide tension of 40 millimeter mercury, and the alveolar gas also has got a 40 millimeter mercury oxygen tension. So 140 essentially in the alveoli also reflects the arterial oxygen tension and the arterial carbon dioxide tension of the systemic vessels. Right, I know I spent a lot of time, inordinate amount of time on this particular slide, but I think if you've understood this, then any session on arterial blood gas analysis, any session on pathophysiology of the lung will become child's play as we move along. So now, if you go to, let's go to the right of this diagram. To the right of the diagram, you have a complete dead space ventilation, right? And if it was a complete dead space ventilation, the gases that come into this alveolus will continue to have the same composition of oxygen, 150 millimeter mercury, and carbon dioxide, 0 millimeter mercury. Remember, no blood is flowing through this particular pulmonary capillary as indicated by the block. And therefore, the blood that exits this pulmonary capillary will also leave with the same composition, that is oxygen tension of 40 millimeter mercury, carbon dioxide tension of 45 millimeter mercury, which is essentially what you get in the systemic venous blood or the pulmonary arterial blood. So this is what we call a shunt. A shunt is nothing but venous blood passing through the pulmonary capillary without getting oxygenated, coming out as venous blood, and this is what we call intra-pulmonary shunt. And therefore, this particular alveolus has got an oxygen tension of 150 millimeter mercury and a carbon dioxide of 0 millimeter mercury. So remember, we said that at the top of the lung, we have a ventilation perfusion ratio of 3.3, that's somewhere here. Therefore, if we look at the value of oxygen, it should be somewhere between 100 and 150. Carbon dioxide should be somewhere between 40 and 100. I'm sorry, 40 and 0. Oxygen between 100 to 150. Carbon dioxide somewhere between 40 and 0. And when we look at these numbers, I said oxygen between 150 and 150 and 40, we're getting a value of 132. We're getting a carbon dioxide which is between 45 and 0, and that is giving us a value of 28 millimeter mercury, right? So if you were to sample blood that is coming out of an alveolus at the top of the lung, it will have an oxygen tension that is higher than an ideal alveolus. It will have a carbon dioxide tension that is lower than an ideal alveolus. And for reference, those numbers are given here. So oxygen tension from a unit that is contributing to dead space will be higher, 132 as compared to 100 millimeter mercury in the ideal alveolus, and carbon dioxide will be lower, 28 millimeter mercury as compared to 40 millimeter mercury. Now let's look at the bottom of this diagram. We'll try and figure out how we reach the number of 89 and 42 by going on to the next slide, which tells us to concentrate on the left side of the diagram. To the left side of the diagram, this is a shunt unit. And in this shunt unit, blood is going through this shunt unit without undergoing any gas exchange. And therefore, eventually, whatever air is trapped inside this alveolus will have an equilibrium with the pulmonary arterial blood. So, same numbers, just substitute oxygen, 40 millimeter mercury, carbon dioxide, 45 millimeter mercury. It may have received pure atmospheric air earlier till it got completely blocked off for some pathological or experimental reason. Once it got blocked off, this trapped amount of air just had enough time to equilibrate with the blood flowing through that pulmonary capillary till it reached equilibrium with that blood. And the alveolar now gases in that particular trapped or airway blocked alveolus will have an oxygen tension of 40 millimeter mercury and 45 millimeter mercury carbon dioxide, which, as you know, is similar to the pulmonary arterial blood of 40 and 45. Right. Now, when you look at a VQ ratio of 0.63, which is there at the bottom of the lung, we should get a value not extreme like we are seeing here, but somewhere between these two values. So oxygen should be somewhere between 40 and 100, right? And carbon dioxide should be somewhere between 45 and 40, which is what we get when we look at these numbers. 89 and 42 are the numbers that we see there. Okay. So essentially, if you have a shunt unit, which is what we see at the bottom of the lung, the oxygen tension will be lower than what is coming out of an ideal alveolus. And if you look at the carbon dioxide, a shunt unit will contribute to a higher carbon dioxide level as compared to the ideal alveolus. So in comparison to ideal alveolus, oxygen is lower and carbon dioxide is higher in the pulmonary capillaries that are perfusing alveoli at the bottom of the lung. In contrast to the ideal alveolus, alveoli at the top of the lung have a higher oxygen tension than an ideal alveolus, 132 millimeter mercury, and a lower carbon dioxide tension as compared to the ideal alveolus. And this is how you find that every single blood pulmonary capillary that drains from the millions of alveoli that we have across these 7 slices of the lung will eventually come into one common pulmonary vein, conceptually a common pulmonary vein, not one vein, and it will eventually reach the left atrium as a mixed blood. And therefore, you will get a composition which is closer to the ideal alveolus. And depending on the amount of shunt that is there, it may go below 100 millimeter mercury if the shunt component is higher, and it will go higher than 100 millimeter mercury if the dead space component is higher. Now, I also want to draw your attention to these 3 numbers. If you total up 132 and 28 and 553, if you do that very quickly, you'll arrive at a value of 713 millimeters of mercury. To this, you add 47 millimeter mercury, which we said early on in today's class, that is the water vapor tension at body temperature of 37 degrees Celsius. You get a total value of 760 millimeter mercury, which is according to Dalton's law of partial pressures. It says the total pressure exerted by a mixture of gases can never exceed the total atmospheric pressure at that level. And presuming at sea level it's 760 millimeters of mercury, 132 plus 28 plus 553 plus 47 will give us 760 millimeter mercury. The same mass will work out here also, 100 plus 40 plus 573 plus 47 and so on. So you find that the nitrogen tension also varies in the alveoli from 553 millimeter mercury at the top of the lung, 573 millimeter mercury in the ideal alveolus, and 582 millimeter mercury at the bottom of the lung. So I think I will probably stop there today. We have another 10 or 12 minutes left. So I'd just like to summarize at this point that there are 3 or 4 take-home points that I would like to say. One was what we learned yesterday, that ventilation and perfusion increase in quantum from the apex to the base of the lung for various reasons that we saw. We also we should try to remember that the ventilation increases by a factor of 2 as you go from the top to the bottom of the lung, whereas the perfusion increases by a factor of 10 as you go from the top to the bottom of the lung. Today we learned a new concept of ventilation perfusion ratio, and we said that the ventilation perfusion ratio is 3.3 at the top slice of John B. West model. At the bottom slice of the model, it's around 0.63 or so. And therefore, the VQ ratio, as you move from the top to the bottom of the lung, decreases. So while ventilation and perfusion increase from the top to the bottom of the lung, the VQ ratio decreases from the top to the bottom of the lung, and we get an ideal ventilation perfusion ratio of 1, somewhere centered around the hilum of the lung, the third or fourth rib, in the erect position. Fact number 3 or summary number 3 would be that apical alveoli, by nature of their being more expanded at the top of the lung due to the larger transpulmonary pressure that exists at the top of the lung, they will contribute to more ventilation, less perfusion because gravity allows less blood to flow to the top of the lung, and therefore the alveoli at the apex of the lung will contribute to what we call dead space ventilation or wasted ventilation. And these will reflect in the blood gas values as a higher PO2 and a lower PCO2 as compared to the ideal alveoli. Last point that I want us to remember at the end of these 2 sessions is that the basal alveoli essentially have more blood flow going through them in contrast to the ventilation when we compare to an ideal alveolus. Therefore, the blood flow through these units is much more than the ventilation. The VQ ratio is less than 1. And when we say that a VQ ratio is less than 1, it contributes to a varying degree of shunt. The closer it is to 1, the lesser is the shunt. So if you say 1 is an ideal alveolus, minus 0.9 would be a shunt. And if you go to the plus side, it will be a dead space ventilation. So the more negative you become, the more you go to the left of the diagram, it contributes to shunt. And 100% shunt will result in venous blood flowing through the pulmonary artery without getting oxygenated and coming out as completely venous blood, which is what happens in atelectatic areas, which is what happens in diseased lungs, such as ARDS, which is why we have such a huge problem maintaining oxygenation in these patients. So patients with intrapulmonary shunt, the greater the shunt, the lower will be the PO2 and the higher will be the PCO2 in these shunt alveoli, which is compared to the ideal alveolus. Right. Now I just want, I know these slides were initially made, believe it or not, in 2000, somewhere between 2000 and 2002 by one of my postgraduates. I really wish he was on this, but I thank Karthikeyan Dandapani for all the initial groundwork that he has done way back 20 years ago. So that's my entire family for you as it has grown over the years. And I would like to bring on the last part of the slide, which is my intense thanks to, both Anita and Manjunath